That made you jump? That's just the beginning, boys and girls. I know that some members are missing. Councillor Murray hasn't arrived, but I think we really ought to crack on with the meeting, because I think we all want to get home, don't we? It's hot, sticky, and yeah. So, are there any apologies for absence? I know I've got apologies for Councillor Barrett and Councillor Turpin, and Councillor Griffin has kindly stepped in. So thank you, Councillor Griffin, for standing in. And Councillor Wildey's not here. So you've got me this evening, folks. So make the best of it. And before we start, I'd quite like to say I'm not one to stifle debate, and I certainly would never do that. But I do hope members will keep their questions to the point so that we can answer them quickly, because we gain nothing by wittering on. We all get a bit bored. And as I said, I'm the biggest witterer of all. But I would appreciate it this evening if we could keep it as sharp and as quickly as possible. Okay? Thank you very much. Okay, and now I've got oh gosh, there's lots. I'd like to welcome Councillor Housegrove and Councillor Cooper, who are here tonight, and you're going to be representing the CYP, I understand. Yeah, so that's great, and that's super to have you here. All right? Right, come on, Michael, keep me up to date, keep me going. Can I sign record of meeting, I think, is next. Can I sign the record of the meeting held on the 10th of March? And yes, and yep. Okay. Yep, there are no urgent matters. And has anybody got any disclosures of interest? Nope. No whipping? Okay. Righty-ho. So then we're going to go on to item 5. Now, before we start item 5, I think you have a paper in front of you that's from Louisa Scullett, who's Medway Parent and Carers Forum. I intend to have this put on the screen for us all to read and pass comment afterwards, yeah? I will say, before we go on any further, because I hope not to say an awful lot this evening, I cannot express my disappointment in this paper. I feel that there's very little that has moved on. And I do understand, Emma, and I hope I'm not being rude, because I think you all work extremely hard. But reading this paper, I could have been reading this 5 years ago, and we haven't moved on, and I would have liked to see more positive information. So that will be the last thing that I will say on it, but I'd like that minuted and noted, that my disappointment. And I am sorry to say that, but I have to say what I feel. Dan.
Chair, I totally agree with your last comment. Can I just ask when this was given, though, this item? Was it given a day ago, or was it just this afternoon, or have I missed it being emailed out? I don't know.
Sorry, yes. The representations from the co-opted member on CYP ONS committee, they came in sort of about 4:30 this afternoon, so there wasn't quite time to email them on. No, you didn't, sorry.
So are members agreed if I put it up onto the board and then we can ask questions, etc. afterwards, yeah? I really am jumping the gun. I should have invited you, Emma, to introduce the paper first. I was so anxious to get these remarks. Yeah? Okay.
Thanks, Chair. Before Emma just goes into the detail and taking on board the comments that you've made in terms of the progress, I think we all recognise, don't we, that there is a challenge, not just within Medway, but nationally, and in fact internationally, around supporting children and young people with their mental well-being. What I think we can actually do, though, Chair, is to talk through some of the positive outcomes that will give you some reassurance that progress has been made, and recognising that we all want to move quickly and we want to move at a pace that will actually deliver the results that... and there I was gone. I'll floor over to Emma. My mic's gone off.
Mine is flashing.
Thank you, Chair. So just looking at the pace and the issues, I think what we'll be able to do in the paper is give some reassurance, actually, and including to members around the recognition that there is clearly more for us to do, but actually we are starting now, at least, from a positive position in terms of moving that agenda. So, Emma.
Thank you. And obviously, we, as always, I always welcome all comments because it's part of what we do. We need to make sure that we are following the way. This paper is basically an overview of some of that work. And as we all know, we've become that integrated CCG. So a lot of this work now is about consistency of offer across Kent and Medway. And I appreciate within the paper, it may not feel that Medway is reflected strong enough in that. But I can totally assure you, myself and my colleagues from Partnership Commissioning are champion Medway at every meeting and at every point to make sure that we understand the financial, the kind of the personal impact on any service that's been looked at. And I'm very happy to talk through some of more examples more in detail to actually give that. Some really kind of key examples. We've got Albert with me today, who is now new transitions lead between the children's and adult services. So he's very happy to answer questions around that because that's a real positive move, and the work he's been doing is really going to have an impact on our young people. Kind of some of the pilots that started as well, there's Care Navigators pilots, which is within our Care Leavers service. We were instrumental in listening to what the Corporate Parenting Board were telling us and making sure that we were one of the first sites to pilot that, because our young people were telling us that they were struggling to access health pathways as well. So wherever possible, we are really trying to make sure that we are leading the way, piloting that work when we're hearing that that's going to really benefit our children and young people, so that when we come to actually commissioning broader services that go up to 25 that are right for our young people, we learn, we listen, we're using evaluation, but we're also led by our young people as well. So that's what we've tried to do in the paper, but I welcome any comments, obviously.
Michael.
Sorry, members. I know we said originally we thought we could put the comments from the co-opted member up on the screen, but for technical reasons we can't do that. But everyone's got a copy of it in front of them on their table.
So has every member had a chance to read it properly, or would they like a couple of minutes to read it through? Yeah? Yeah? Okay, so if I give you a couple of minutes. Has everybody read it? Yeah? Okay, then perhaps we'll move on. I think we all agree these are pretty fair comments and well worth listening to. So I think we have to send our thanks, Michael. for it, because it's extremely helpful to have something, because this comes through our post bags every day, doesn't it? Anyway, I'll open it up to members.
Right, thank you. And I think, yes, we should thank Lisa Scarrett for saying what lots of people here think and feel, as you're suggesting, Chair, through their inboxes. And notwithstanding what you said, James, I do want to focus on positive things, but the issue is there to be faced. There has been a problem with transition from children's to adult services for a long time. There are multiple and severe problems within children's mental health now, never mind about when people get as far as transition, with waiting lists unacceptably long, and people being pushed into, always with good intentions, very often a kind of sticking plaster situation through a school counsellor or a community counsellor or a community group, who frequently fail to notice a serious condition. And I include in that eating disorders, I include in that things like personality disorder, things like schizophrenia, those emergent disorders that will happen just at the age that people are going into transition very often. So I found the statistics sad and scary. 82% of young people saying that they'd experienced problems with their mental health and well-being. Over a third of young people saying that they've got mental health problems and are trying to access treatment now. So I know you didn't want to diminish that, James, and I know it's important, not least to give the people in the situations I've just described hope. It's important to focus on positive outcomes. But I think we also have to take responsibility for the fact that things have been unsatisfactory for a long time. When we have colleagues from KMPT here, when we see people from NELFT, we're frequently told how marvellous everything is, how there's never been a better time for mental health funding, how things are really improving. The truth is, there's a very confused landscape of providers. There is a recruitment crisis, and demand is at an unprecedented high. Now, I want to hear from everybody about how they're going to actually deliver the good intentions in the document that we've got. But I would say again, this document, long, comprehensive, and really important though it is, and it does explain some things to me that I genuinely didn't know how they worked. In its entirety, it describes the situation in great detail, but it doesn't do much to have a real plan for moving forward with milestones and outcomes and quantitative data so that we can see how things really are going to improve. So first of all, I would like to know, what is the delivery strategy for these intentions? And when can I expect to be able to tell parents of 15 and 16-year-olds that they're very worried about, that they will get the treatment that they need now, and that when they turn 17, it will continue and they'll get the right treatment? The other thing that I particularly want to raise is this constant cycle that people find themselves in of having a crisis, having 6 weeks intensive treatment, going into a community setting to get a bit of help, then being told they're closed until the next crisis. And when the next crisis comes along, they have to describe the whole thing again to somebody, making actually having a mental health crisis worse. Nor do I accept from my own direct experience that there is anything like enough of a robust service going on at the acute hospital for mental health patients. With 2 accidents close together in my family recently, I had very long periods in A&E. And in both of them, one in the middle of the day, in the middle of the week, one at the weekend, in the hours up to midnight. And I saw, on each occasion, several people in mental health crisis, some with a mental health worker accompanying them, great big file of stuff, young, older, and middle-aged, at least 4 people. And by the time I left, none of them had, as far as I could see, seen any specialists. They were still waiting where they were. And in fact, I spoke to a parent, and she said, this happens a great deal. A child with eating disorder. This happens a great deal. There's never anybody here who can help my daughter, but I don't know where else to go. So with that sort of disparity in real experiences, and, you know, anecdotes sometimes are important to recount because they're real. They were real experiences that I had. With a disparity between those, you know, all of the good intentions in here, all of the really good outcomes, I would like some assurance about how we're going to manage the period before transition itself, and afterwards, and try and see this, instead of sort of 3 sections that people have imposed on them, as a long-term plan for the services to be there as long as you need them, person with mental health crisis. Not, you know, the bit that you're waiting for because CAMS have let you down, the bit that you're waiting for to hear about transition, and then the bit that you're waiting for to get into adult services. I do feel very passionate about this. I've got direct experience and a long career of working with young people. And actually, in that time, I don't think I have seen things quite as bad as they are now. And I know there's loads of good reasons and other things that have happened, but it's not acceptable. And it makes a nonsense of saying we're a child-friendly city if this is how our young people are feeling.
If I might first, Chair, and Councillor Murray, the points that you make, I think, are set out in the paper. I think we all accept, and I'll just reaffirm, because I did think I emphasised that the issues that we've got at this moment in time around mental well-being of our children and young people, and I know you were talking as well about adults and clearly about acute provision. Obviously, the paper here today, we're talking about children and young people, and that move forward. And so I'm just, you know, I'm not accepting the points that you make about the hospital and that acute piece around acute inpatient care and stuff like this. But I think we probably need to come back to that, because that's part of the broader picture about what we do through the whole mental health pathway.
Forgive me, really, James, to interrupt you. I wasn't talking about inpatient long-term care. The people that I saw were a million miles away from that. They're people who'd gone for help because they didn't have anywhere else to go, or didn't feel that they had anywhere else to go.
Yes, and thank you. But I was just picking up the point that you made around, you saw children, young people, older people, and families at Medway Hospital. And quite clearly, I'm assuming it was at Medway Hospital, but we know that the actual configuration for mental health services are not based on that acute hospital. They're based around that broader trust that you mentioned in terms of
James, I think
KMPT.
you've got an excellent point there, but I'd rather carry on and get a response, because I think we want answers about
I'm moving to that, Chair, yeah.
Okay.
But the context, before I bring in the colleagues, is this is a NHS programme that is focusing on rolling out national ambitions, but we're trying to adapt those and make sure that they are delivered at a local level. So there are some constraints, and I'm not shirking away from the fact that we can change that. And of course, moving into the Integrated Care Board in 1st of July gives us more control over how that local picture is shaped. So that's a positive thing for us. But the reality is that we've still got some, you know, I'm being really pragmatic in essence, we've still got some work to do, which is what you're describing, in order to be able to articulate all of the points that you've raised. But I'm pretty sure that Emma will go through some of those elements and pick out some of those questions that you've raised and give you some answers to.
Thank you. And maybe I might recommend that the crisis and complex pathway work maybe come here, because I think that will answer a number of your questions. Because within that programme, we've been forming a tighter network with our acute hospitals for exactly this issue that you raise around those going into crisis. We have seen an increase in our young people who are experiencing eating disorders or disordered eating enter into A&E emergency departments, and unfortunately be admitted onto wards as well. And that is one area that we're very much trying to tackle within that programme of work. So I think that would be a really interesting piece of paper, a report to come to this board to give you that kind of particular answers, because we've now got matrons in the hospital that are mental health trained to work with children and young people that are helping assist with that transition. We've expanded our crisis team as well, so they now can support a young person up to 12 weeks post episode. that also can be within the sort of household and the community as well as the hospital. So I'd really welcome bringing that back, if I may, so that actually can answer some of those questions. In terms of the kind of transitions, I'm going to hand over to Albert, if I may, to talk about some of the work, and I think that may answer some of your other questions around that transition point as well.
Thank you, Councillor Murray. It's my first time here, so I just wanted to talk a bit more about your question in terms of the pre-transition, transition, and then post-transition. I've been in post since December last year, and we've put some strategies in place to mitigate a significant part of what you mentioned. In terms of pre-transition, what we've done is to instill a locality, a transitional team meeting. In Kent, in Medway, we do have NELFT representing the young people, providing support for mental health support for young people with mental health needs, and then KMPT providing the support for post-18. There is a gap in there, and we recognize that. So we put a strategy in the sense that we have these locality team meetings where we have representation from both NELFT and KMPT, and also social services to discuss young people's needs. Now, this starts at 17 years. 17 years, that's a pre-transition, to have a strategy, so when they get to transitional age, which is 17.6 nationally, there is a plan for them. There's a plan for young people. At that point, we do recognize that there's a role for carers, and we do invite them onto those meetings to discuss young people's care needs. And post-transition, when they've transferred to adult mental health services, there is the increased support from age 18 all the way to age 25, and where clinicians do increase the input that they provide young people during that time. And we recognize that actually it is difficult in terms of staffing. It's a national challenge, but the strategy that has been put in is to recruit abroad. And in the last, if I'm correct, in the last few months, I think we do have some people joining in from other countries, and I can't give you the number as yet, but it's some of the strategies that we put in place to help improve the workforce challenge that we do have. So yeah.
And if I may just add one other point around pre-transition, we now have our Medway emotional support teams working in schools, and we also have emotional wellbeing teams who are in schools to exactly start early identification of where presentations, behaviours are starting to highlight or suggest particular support as well. That has been a significant development that is rolling out in all of our schools. We also have a new service which is rolling out working alongside social care, which is for those that are also on social care registers, and that is offering a therapeutic support just below the threshold around CAMHS. I didn't actually put that in paper, I apologise. I'm very happy to put that information, but that is a very early services, but that will be available to anybody who are entering on a social care caseload. And that therapy would be PBS, which is positive behaviour support, VIG, which is like communication intervention, CBT. It'll be a whole host, and that will be a team working around to tackle that early intervention that you're very right that we need to do.
Just come back, please, Chair. And absolutely, it would be nice to add a recommendation to have the crisis paper come back. I think that is going to be really important. I suppose, I wonder if you can explain to me then why, when NELF come here, they say everything's all right. They tell us about all the people that they've got going into everyone's home. They are very convincing about the fact that they believe there are people at the acute hospital 24/7 picking up all of these things. And, well, that they describe themselves as an organisation that actually on the ground I don't think people necessarily recognise. So I don't know if you've got any observations to add about that, but, you know, they will not tend to describe being overwhelmed with all of the people that are coming forward. And look, as a school governor, I've had direct experience of the head teacher coming to talk to, in the case of this school, the foundation governors, to ask for money for a sensory room in a school in an affluent area in the Grammar Stream because they're overwhelmed with children with mental health problems. And, you know,
Councillor Murray, I don't intend to stop you because I don't want to stop debate, but I think I want answers rather than questions.
Yes,
and I think we need a lot of answers here.
I'm coming to get an answer about what was said about the emotional support team in school. But it isn't only that people have got disorders, is it? It's the causal things. And that head teacher said that in a girls' school, the Black Lives Matter movement, the violence against women difficulties had impacted hugely on the young people in the school and had made them feel frail and frightened and worried about things. And similarly, the sort of, you know, situation with the threats posed by climate change. So that's a school in a good position to respond, finding it difficult. So sharing that with you, let's hear a bit more about these emotional support teams. Are they coming to every school? Are they coming to the primary sector, to the secondary sector? Does everybody have a name contact? Can you just, you know, give us a bit of context, please?
Very happy to. It's an area that's very, very close to my heart too, as being a governor too. One of the things I would like to say just first off is that you mentioned about NELF for one part of the system. We've all got a role to play within this. We all need to kind of make sure that the pathways and the navigations our families are experiencing comes together. And I think sometimes it's now for our specialist service, we need to focus before that and making sure that we get that right. And that's definitely where these emotional support teams are. So Medway has 33 schools represented by this NHS pilot. We were very lucky to be awarded 2 teams funding 2 years ago. In the paper that I brought here, I think it was 2 months ago, it does give further details on that programme. That is, we are working with that with NELF to develop this kind of sort of low to moderate needs service, which works in a school setting, for that school, named contact, and it's about enhancing existing services. So if a school's already got counsellor or other services, they will work to form that more comprehensive offer within that school. Because when we awarded this, we were very aware that it was only in a third of our schools. At that time, we developed the Emotional Wellbeing Partnership, and we got additional funding to put into our school nursing contract, who already had an emotional wellbeing team, to increase the number in their team so that we had coverage across all of our schools. Because prior to putting in the application for that pilot, we ran a series of events with our schools, and that's what they told us. They didn't want us to cherry pick which schools. They wanted to address hidden need and address all needs in all schools. And that's what our desire is, and that's what our vision is for that. So we're looking to bring partners together so that the many roles within that, and we have a comprehensive offer that is quality and that we understand as well. So that's our vision and desire.
Thank you, Chair. Obviously, certain things in the report are quite concerning. I just want to focus on the Building for the Future part of the report, which is of the big report, the PDF, which is your page 64. This is what you commit to do for 2022-23, so this is this financial year. I would just like to ask you a series of very quick questions to see how far down these kind of deliverables that you've committed to you are. So the first question I have, Chair, is that you talk about you recruit 2 additional participation workers. So I'd like to know how far, if you've advertised for that or if you've recruited them yet or not. The second thing you mentioned is recruiting 1 additional senior lead for crisis. I'd like to know, again, how far you've got down the road for that. Third question is that you mention in the third bullet point, seeking to increase capacity and capability within the workforce, increasing further. but it doesn't specify any quantifiable increase of staff in that bullet point. So I just wanted further clarity on that. What kind of people are you looking to recruit to substantiate bullet point 3, please? And then the final thing is that you've committed to, by the end of 2021, so this should already have happened now, which is increase the number of inpatient beds at Kent and Medway Adolescent Hospital, an additional 6 beds, 3 of which designated 72-hour beds, and crucially, that these beds don't require people to be sectioned. It can be done in negotiation with the young person without legal requirements. So could you please just update me on those deliverables, please? Thank you.
Yes, of course, welcome to. Our participation workers, we have a role within our youth services in Medway Council who's solely for emotional wellbeing and mental health, pupil voice, developing pathways so that anything we develop, they are at the heart of everything we do. So that is, it's within, like I said, it's a full-time role, and they come to most of our meetings to make sure that we are feeding that through, and they can go back and develop those channels. So that's a fantastic development. There is also equivalent ones in Kent as well. So if there's ever a Kent and Medway development, we're able to balance those views so that we have those consistency of services. In terms of senior lead for crisis, we actually have, there's a new lead within NELF service who covers Kent and Medway, because obviously crisis is a Kent and Medway service because our hospitals are located not just in Medway. And also we have now a CCG lead for crisis and complex, who's an assistant director level as well. So we've got 2 roles that are particularly focusing on that aspect. In terms of increase of staffing, this is obviously an ongoing challenge for us, as Albert and everybody acknowledges in this area. The CCG has got a workforce development plan, which I'm sure at the later date, I'm sure they're very happy to come and talk around that. We have also increased our funding into our mental health services to move away from temporary staff into more permanent, substantial posts, which we all know is more cost effective in the long term in the future. As always, this is always a challenge. It depends on obviously the recruitment and who we're able to retain as well. In terms of the inpatient beds, this is something that the provider collaborative, which is all of the tier 4 inpatient providers across sort of Kent and Medway and the South East. There's different provider collaboratives developed to manage the number of inpatient beds that we have. So you mentioned about our kind of Kent service, which is delivered by NELF as well. They have now, they hopefully will be opening those beds in the next month or so. So we have an increased local access. The 3 72-hour beds are part of that, and they will be definitely non-sectionable beds available over that period of time, where it might be a step down from hospital or a kind of a hospital avoidance to try and manage the crisis situation as well. And NELF are very much on track of opening those 2 in the summer. So they're both very much, but they are provider collaborative programs, they're not CCG funded programs. So there's NHS specialist commissioning.
Thank you very much. Just to clarify on 2 of the quantifiables. So is it the case that you'll get all the 6 beds that were promised by the end of 2021 within the next month, all 6 additional beds? And then on bullet point 1, committed to 2 additional workers. You mentioned progress. Have you recruited 2 additional workers yet?
Sorry, could you just clarify the question? The 2 additional workers for which bit?
It says here, we will recruit 2 additional participation workers to work specifically within young adults who have experienced the crisis pathway as part of an improvement programme.
Sorry, can I just clarify, is that in the local transformation plan? Or is that in the paper? Yes, local transformation plan. So that is across Kent and Medway, the participation workers. One is for Medway, one is for Kent. Is that what it says?
The commitment for 6 additional beds by the end of next month, is that for all 6 additional beds in Kent and Medway Adolescent Hospital?
Yes, that is.
Thank you, Chair.
Say before we go any further, welcome back, Dan, and it's lovely to see you here, looking so well and healthy. Yeah.
Thank you, Chair. I think James is going to know I can't pick out much positive points about the report. I can pick out some great organisations that your VCS organisations that pull you all together and help and support. Because you name them all in the report, we big them up, and so we should. People like Metro and the Sunlight Cafe and all the others, we should big them up because they do keep things going in our community. However, when I just open up the page and you know, you look at the first point there, a total of 1 in 3 young people from Medway currently accessing mental health support from a service. That's nothing to be proud of. That's nothing to be proud of. I'm sure, I don't know, TAPS, I know you've only just come in, but it's nothing to be proud of for agencies, statutory agencies, anything. It's an awful figure. And we should be sitting here actually in, just ashamed of ourselves, I suppose, as a council and as public servants, because I feel a bit embarrassed. And hopefully children, young people, ONS will take it forward, this report as well, because I feel embarrassed that we come to meetings here, we're told so many good things, and I will touch on eating disorders in a moment, but we're told so many great outcomes. And you read this, and you think to yourself, have we been conned? And I know, please don't take it personally with the staff. I know a lot of the staff are doing some tremendous work out there from all agencies. They're trying their best. But this is a shock. I mean, actually, the stats around young people trying to access services is no shock. No shock to any of us. But when you read it on here and we are letting down our young people, you think to yourself, how are we going to get out of this? And a couple of the questions I'll ask in a moment, one of the biggest questions is, we're about to go into this wonderful new structure with Kent CCG. How are we going to monitor this, make sure it's going to be impactful? You've already said about them 2 staff, 1 for Medway, 1 for Kent. I mean, you know, we've got significant issues here. And I'm really concerned, really concerned that we're not doing enough. And the report is really good, and then part of me feels, is this an exercise here? Are we just, and we've never had it before, I'm not saying we have, but is this an exercise to say we actually recognise there's a problem now, because that's good, we recognise it? But there's nothing actually in there about breaking the cycle in families, breaking the cycle of despair, how we're going to get young people out of them issues, because they are normally brought down from families, and I can say that with issues such as eating disorders. I have a very personal thing with that. So I do know that if we don't catch people early enough or change that cycle of despair in families, we're not going to get anywhere. And by the time they become adults, we miss it. And the services that CAMPT run for eating disorders are actually trying to catch up them, and they're always going to try and catch up. They're never going to get there. They're never always going to resolve the problems. And there'll be people like me, which I'm happy to say, that will still be struggling 40 years on. And if you don't catch it early enough, we should all be ashamed if we don't do enough for our young people. For me, also, we talk about new staff, and it's great to see that new staff are being employed. But what about training for the current staff? What about training for the social workers, training for the hospital teams, training, and I'm going to say it, training for GPs to spot these issues? You know, people can't even see a GP, so let alone have them recognise an issue very quickly. So we have a real problem there. So the questions, Chair, are, James, I'm not going to just put you on the spot, but I suppose I should, because you're the representative, and Jackie as well. How do you feel about them stats there? Because I know we said at the beginning this is a positive report, but that stat there, 82% can't have problems accessing service of our young people, is nothing to be proud of here. So how do you feel about that? Will things get better or worse going forward under the new structure? The wonderful, fantastic structure we've been told is coming. What about the current waiting list now? What about the waiting list for these services now? This is a new plan. What about the people that still can't access service for the next few months or whenever this takes time to come into action? What about those people? What about people that are waiting to see their counsellors? Those people that want to get on that list but can't afford private counselling? You talk about talking therapies, long waiting lists. What's going to happen there? And the final one, which I think, Chair, is something for debate at the end, and hopefully the spokes and yourself could decide, how will we now monitor the outcomes from this report? How will we closely monitor, not something once every 6-9 months, how will this ONS now monitor going forward how this progresses? Because I feel we have a duty to. I don't think this is just like a stroke centre we've been robbed off, or another service we've been robbed off from Kent. I feel this is something we owe to our young people here in Medway. So I would like to see something which enables us in in a short monitoring document, etc. And those agencies like KMPT, I'm sorry, Tats, I will pick on you again, need to respond and need to come forward on this. And so I think we really need to watch this, Chair. And I know you said something at the beginning about that, but I really would like to say, how will we now monitor effectively the progress from this paper? Instead of it all being words, we want to see the action taking place going forward from that.
Thanks, Chair. And Councillor MacDonald, as you know, the points that we're talking through here, if you recall my annual public health report of 2018-19, I did set out the challenge because that was focused entirely on mental well-being for our population. So I'm not underplaying, and the points that you raise are really valid. You know, it is a challenge for us to actually address the issues that have been identified here. And the journey that we're on, because of the issues that we'd already identified, it's a challenging one. It's moving forward. We've had a pandemic that's exacerbated the work that we need to do, and we've seen that with the presentations, as Emma's already said, with young people and older people in crisis. So there isn't any underplaying of it. And where I was being really clear, I think there are some positive things in the report, and I think we should all accept the report gives us the clear picture, and we need to work from that. It identifies the problems and the challenges that we face, because if we don't do that, then we're not able to actually, what have we done? Now the points here raised around how will we measure this, remember, from the 1st of July, we are part of that system. We will be, as a local authority, part of that integrated care body. And we've got a formal seat. Our leader will be chairing the Integrated Care Partnership. In 2 years' time, it will be a Kent chair in the first instance with us deputising. And within that process, we are developing the integrated care strategy. And I can tell you that mental health is one of the priorities for the Kent and Medway integrated care body. It's not the CCG. All of the people, all of them who were managing the CCG are no longer in the roles that they were in the new order, and hopefully that isn't assurance in terms of the work that needs to be done. That's just making a point that it's a different distinction. So in terms of that monitoring, it's us. We will be part of that process. All of the challenges that have been faced here, and I think you did bridge to it, and I know you've got excellent experience in this, Dan, because of the work that you do. The family context, you can't separate children's mental well-being from that broader context. The stuff that we're facing now, the credit challenges that people have got, the cost of living, increasing fuel prices, all of those things will weigh quite heavily on people's ability to be resilient. So I accept all the points that you raised. There isn't any soft-soaping or acceptance from my perspective. I'm just referring back to the fact that I have tried to ensure that there is a spotlight placed on this, of which I'm proud of, to be fair, because we're now debating those critical issues. And what we need to do is what you've said, is to move forward and deal with the challenges that are being presented. And I think, you know, we'd be quite happy, I would suggest, the team to come back in a periodical process through you, Chair, of course, because some of the issues related to children's ONS, you probably need to just make sure we balance that out in our democratic team so that we don't overlay things. But equally, this is a programme for everybody. It doesn't really matter where it sits. I think we've all got to recognise society needs to work together to deal with these challenges. And all I can do is give you that assurance that we are trying, and Councillor Murray's points about the providers, you've heard a term, and the point that was made around these provider collaboratives, that is an attempt, and I'm going to say it's an attempt, to remove the disconnect that has previously been there between we deal with children, we deal with adults, we only deal with people who are acutely ill, we only deal with people who have got... It's to bring all of that together to give us a sense of we're all in this same boat, we're all rowing in the same direction, and hopefully that should give us some solutions to the challenge. But it's not going to be easy. I'm just going to reflect on that.
Chair, can I just come on the training then, the training for current staff and the waiting list, please?
Yeah. I'm happy to share the full comprehensive training offer that has gone out, because actually this is an area that we've had significant offers in. We've recently done bite-sized training for acute hospital staff around mental health and handling behaviours that challenge. The whole LDA programme, which is the LDA Alliance, have offered a number of training for support, because I think we need to also acknowledge that you talk about waiting lists. We have various different pathways. We obviously have those that are neurodevelopmental, diagnosis, which obviously is where we have our significant waiting times, sadly. Our mental health services are actually pretty quick, believe it or not. at least 80% are accessing services within 18 weeks. I agree that's still far too long for us, and we will work hard to make sure that in time, but that is the national marker that we're having to work with our services at the moment. But we do monitor that performance, we do look at that regularly, and we've recently recruited 3 new members of staff into our Medway team to be able to reduce waiting lists even further, to increase and expand the offer to some of our more vulnerable groups, and also have a focus around our SEND young people and their families. So we're doing what we can significantly to try and make sure that we address that, and we do monitor that. But the training, like I say, I'm happy to submit that afterwards, because I can't off the top of my head right now think there is a significant behaviour and mental health training programme across all stakeholders, all partners, and about growing our own is real heart of that. Yes, it does. Yeah.
Adu, yeah.
Thank you, Chair. I'm concerned because I'm reading the first statement about parents getting frustrated that young people's mental health quickly deteriorates when you know, the young people are transitioning. We all know COVID happened and it impacted young people's learning. So those who are 16 now and 16 before, it really impacted their learning. I have a 16-year-old myself, and who this year, you know, studies was a real challenge in terms of getting, he suddenly felt pressure, you know, because of COVID, the speed in which they have to learn, the speed in which they have to revise, the speed they had to catch up on a lot of, you know, topics and stuff. You know, last summer I had to get extra, you know, tuition for him, which was a dent to my pocket. And I can imagine many other parents and parents who can't actually afford the extra tuition, you know, and the impact, where I'm actually going is the impact on mental health that, you know, suddenly they're feeling this pressure, suddenly they're feeling that they have to study extra and the time isn't there for them. So that's that. And, you know, many of the parents in my ward, you know, I get emails, you know, I get contacts where they're telling me that, you know, they're worried about their children, they're worried about their grandchildren, you know, particularly, you know, some of the issues Councillor MacDonald touched on about eating disorder, you know, so those problems are there. And, you know, we can see the stark difference from previous years that is really on the rise. Now, my question is there any smart way, or how are we going to tackle this, and how will parents feel supported? You know, because parents are at their ends. You know, that's the complaints that I'm getting. They're at their ends. There's no communication as to how, you know, their children, you know, or young adults rather, are going to be supported, you know, because they feel like they've been left on their own. You know, they're not getting access to these services. How are they going to get supported going forward will be my questions. I know the school are trying, some of them having to dip into their own budget. Like, for instance, my son's school having to do like breakfast to make sure that children are getting food during the exam period, but not many schools can afford that. You know, so I think we really need to look, you know, give it a holistic look as to how we're going to tackle this problem, that we won't now, in the long run, when they're now into adulthood, you know, they are really struggling. We're now going to have, you know, what would you call it? A high percentage, you know, of young adults, you know, in mental health care, because we are not really now we're not doing the early intervention as we ought to. Yes, they got it, you know, whilst they were like much younger, but now the early intervention still continues, and I don't really see the plan, you know, as to how that is going to be tackled. So I think that's what I'm after this evening, that what is the smart way forward? What's the strategic way forward going forward now? Thank you, Chair.
Thank you for your question. I could talk for hours on what you just suggested, because in terms of the strategic and delivery plans, we do have a Medway Local Transformation Board still. which meets with different partners across. This was originated when Medway had its own initial plan. So the one that you've got as in the appendices, obviously, is our new Kent and Medway kind of a cross-hatching one. But underneath that, we still do have a group that meets regularly to look and review and to kind of monitor. One of the approaches within that identified is our Thrive approach, and this is in the Kent and Medway one as well, about we've all got to understand the graduated response towards our services and towards our people's, children and young people's and their families' needs, and making sure that we have awareness over what we have around signposting, what we have when we first have concerns raised, where do we go first, where do we go next when maybe we need something that's a bit more goal-based, a bit more kind of thorough in terms of intervention, and then where do we go for our specialist services? I think sometimes we're too quick to jump to specialist services saving the day. And so our focus has been very much around that early intervention type approach, and that's where our plans have been about creating that vision. So within that Thrive approach, we've been supporting in GPs, a number of them have social prescribers now to support families directly. And we've been working with those that have been based in some of our PCNs to have a new tool which helps them guide and support families around navigating services and actually obtaining feedback as well. So for us, it's very much important that we're by the side of our families, accessing services but helping that navigation as well. So that's one example of work that we've been doing. Another one is around the neurodevelopment, those suspected or diagnosed with a neurodevelopmental condition. We have a community support, which is peer support for families. And again, they're there alongside our families, regardless of what services they're at, they'll be there. And we do work very closely with Lisa and her team around the Medway Parents and Carers Forum, regularly making sure that they're at the meetings with us, that we regularly work with them to find solutions as well. So whatever we're doing, we're trying to make sure that we have family voice and that we make sure that we've got those supportive services alongside our more specialist services or early intervention services, so that we have that more community and specialist package for our families as well. But I'm very happy to bring back a more kind of developed plan, definitely.
Just the only thing missing that I'm also expecting to hear is how will first-timers, parents who are actually coming across mental health among their adolescents, where do they go and how will they get the support? How do they get access to this support? It seems like, how would they come on your radar? I'm looking at the strategic plan on that too. Thank you.
No, I totally agree. And that is all about communication, isn't it? And awareness. It's that signposting. And that's about us working with the system, with stakeholders, with partners, with community to raise awareness of where the first port of call is and how people can learn those top tips. We work very closely with, obviously, our public health colleagues around the health improvement agenda to make sure that those tips are out there, families access them through social media and through other areas. We have a mental health network with our school colleagues, with their mental health leads, where we also talk about that communication, what messages we put out as a consistency, where we can access families, where they spend the majority of their time as well. So we're using our existing system to make sure that mental and emotional well-being is mentioned, that resilience is wherever we can, is fed through whatever programme we can as well.
Right, just to say thank you, Emma, and thank you, Albert, for coming along and answering our questions this evening. I do appreciate that it's difficult, but as you can see, members are not happy with this, not happy at all.
Chair.
Sorry.
We've had some members from Children's.
Oh, they didn't. Oh, sorry, I didn't see you indicate. No.
Thank you, Councillor Purdy. Yes, we've been asked to come along because Clive Johnson, our spokes, is on holiday, but in Children's Committee, Pat and I usually do housing, but we've read the report and we do have a couple of comments. And first of all, I need to confess that I am interested in mental health. I did want to be a psychiatrist at one point, but I've worked in schools for 35 years, and I think we need to recognise how schools are really working hard for the well-being of our children. Some of the staff I meet in schools, and I'm Vice Chair of Governors of 3 Medway schools, are really skilled up on talking therapies, draw and talk, and also they recognise they're key workers for children, and they recognise just by a look and read the behaviours of children, which is the first starting point. And as a head teacher, I visited Finland, and I have to say I was absolutely my breath was taken away about how they get in with an integrated service from the get-go, through education, through social and emotional well-being in schools, which underpins everything they do. Now, from we've read here, there's a lot of meat on the bones, and it's moving in the right direction, but there's the plan, but there's not enough, and there's the do, but it's got to be quantifiably checked. So you need to be plan, doing and checking. And also, you know, some of my constituents feel like when their children are having wobbles, they're like on the magic roundabout. It has to get really bad before they get the right intervention. And by that time, I mean, I've got a 9-year-old that I'm working with the family at the moment. She's on a 3-year waiting list to be diagnosed as neurodiverse. She has all the traits. And I know that list is long because of COVID, but now she's taken to self-harm, she's become agoraphobic, she won't go to school, and she's 9 years old. And there's not a lot out there for mum, really. But what there is out there for mum is doors closing with Medway saying she doesn't deserve an educational healthcare plan because she hasn't got a neurodiversity diagnosis. And what I think is, if you sort children like that out early and get them in the right schools, get them with a bespoke blanket of care, cocooning them, then actually that early intervention stops a lifelong dipping in and out of social care. One of my sisters is a psychiatric nurse, and you know, she embraces early intervention, because otherwise, unfortunately, you get a lot of people that are, you know, have a revolving door, like to her unit, but, you know, also in the prison service. And all of that costs us more than getting in and sorting out the issue early on. And, you know, I love integrated care, and I'm really a big fan of Medway Can at the moment. But, you know, sometimes you cannot be, you know, like, you know, Coco the Clown and pounce on people at the Medway tents, really, because people are not always Tigger-like people. There are lots of people, like my husband is totally quiet as a church mouse, you'd never would put us together, but it does work. But, you know, Medway Can jumping out at me will be good for me, but that would send him 5 miles in the other direction. So you've got to make it an approach, not one size fits all, but, you know, a bespoke approach, so early intervention. And, you know, I think the best thing for our children is to encourage them to speak about mental health and to get the services as early as possible, and as you know, as bespoke and as also as long as they need. You know, if someone's just done their 6 weeks in you know, with a psychiatric nurse, you know, some might not need the 6 weeks, but some might need the 8 weeks. So you really have got to fit that to that person, not just use it as a tick box exercise. And then also, you know, Councillor Cooper and I, on children's services, you know, we're worried that the breastfeeding figures are going down in Medway. And you know, I think breastfeeding is that really good connection and that reciprocity with the mum and that, you know, attachment that we all need to thrive. So I hope the integrated care will encroach that as well. And you know, back to what Councillor MacDonald says, you know, how are we going to recruit? How are we going to retain? You know, do we need to be growing our own? Because actually, I don't know if you've noticed, there's a national crisis of people to do any kind of jobs. So, you know, we need to be thinking out of the box and getting the best for Medway children, because they deserve it. Thank you, Councillor Purdy.
And thank you for coming along and making your comments. I think we all...
I think we're a bit
far away. Yeah, thank you, Chair, for inviting us. This mental health in young children and young people has exercised our minds on Children and Young People's Committee, and especially the Corporate Parenting Board. With regards to what is happening here, the figures are really staggering, you know, because it's really, well, it's very difficult to see just how many young people there are out there with mental health. As Emma knows, I was part of the LINK programme that started this off with schools, and hopefully now that's going to continue and carry on, because I know it's working well. But, you know, there's things that we are not really doing. And councillor colleagues have been asking the relevant questions. I've had questions written down here and they've all been asked before. But there are a couple of things, you know, really that I think that we ought to be looking at. All these words, it's a very long document, and a lot of this we have been doing on CYP and CPP, and it looks as if this is a coming together of what we have been discussing for, what, 2 years now or more? So this very long document, I recognise quite a lot of what we have been talking about on those two committees, with various presentations and everything else. There's references there to children in the secure estate. Well, as we know, Joe and I went to Cookham Wood, and I also went to the presentation about the secure school. So how is that going to really make a difference within Medway? Because that is hopefully coming on stream shortly, we hope, from Oasis. But I have to say that in all these long words, there needs to be an accountability. We've got to have the SMART target, you know, the SMART, it's got to be there, it's got to be measured, it's got to be accountable. We've got to have feedback on what is happening, because I noticed that some of the figures are not quite up to date with 2022. There are various parts in this document that go back 2019, 21, and all the rest of it. So we need to have more up-to-date information, what is going on out there. We've also discussed at length about the issues with NELFT and the long waiting lists that, you know, that's happening, and I still feel that that is still happening, because, you know, they are becoming now overwhelmed, I feel, with, you know, with young people with mental health issues. And I know we have talked about this a lot, and also CAMS. You know, we've you know, had CAMS come to the meeting and talk to us, but it still doesn't seem as if there's still enough out there for, you know, children and young people with mental health. And we've also really need to get to grips with what's happening with our children in care and our care leavers. Because Joe and I, we are care leaver champions, you know, and as she said, that we are looking at the housing mostly, but our care leavers need our help, because some of them, they leave care, they're thrust into the world, you know, and they haven't got backup behind them, and they need proper backup, they need our help, they need everything that they can get, and, you know, that is one area that I think is not quite really documented here. So if we could have some more about that, please. And lastly, I'm going to say this again, and Councillor Lammas will not mind me saying this, but I brought this up at Children and Young People's Committee last night, because there's sections in here about children with ADHD and autism. Again, I'm going to reiterate that I think we need an autism champion, because this is such a pertinent thing that is happening with our children and young people. A lot of the things with mental health are identified in this document as being children who have got, and young people who've got autism. So I think I'm going to push this forward again, and I won't stop until somebody says, yes, we're going to have one. So that's the last thing. But we need to have measured targets, we need to have outcomes, and are we going to get any kind of report from this committee coming to Children and Young People's Committee? Because I feel there's such a lot in here that it is children and young people, and I really think that we need to see this on CYP and at corporate parenting to some extent. Thank you.
That was a lot there, thank you. I will. More than happy to put this on any agenda. So, you know, we'll organise that and make sure that it does in terms of that. Because you're right, this is one of those areas that needs everybody in both kind of committees to be very aware and very passionate about. So I welcome and thank you all those comments. In terms of accountability and smart targets, I totally agree. And I'm very happy to kind of produce that and make sure that all boards are aware of that. I think one of the things I would like to say is that obviously it's, in terms of us understanding this area, it has taken quite a lot of unpicking to understand this because of the differences in terms of commissionings of services. We are now starting to understand that, so I'm hoping that over the next year, I'm setting Albert up a little bit, that we'll see a lot more difference, a lot more different improvements in the stories and the kind of the cases that we hear locally. So I'm really kind of, that's my desire for that. I really do hope for that work. I think also in terms of a lot of the other community services, we should know more about kind of their impacts, their data, and hear more about kind of cases going through their services as well, because that is our desire, as everyone has talked about today, is that we remove people's need to transition between services, that actually we have services that walk with you and beside you and navigate with you, and that we're earlier in that intervention as well. And that is definitely our desire, is to move towards that as well.
Yes, I will. I just wondered if Mr. Mutakati might want to say anything about this. I'd like to know whether, you know, KMPT feel that the plan, you know, you're ready to play your part in what is a sort of a, you know, a nuanced and refreshed approach to try to get this continuity rather than, you know, compartmentalise the children's transition and adults. And I'd be interested to know whether you feel that KMPT are part of the whole care navigating scene and that you've got the resilience and resources in readiness to play your part, please.
Yeah. Shall I respond to that, Chair? Thanks for the question, Councillor Murray. Firstly, can I just say to Michael that I'm in a different role now, so I'm not here representing KMPT. I did work, of course, for KMPT, but I'm quite happy to respond to that. There is an active program. Yeah, I noticed that as well. So that's why I felt I had to ask Michael to correct in the future. But I can speak to that, or at least respond to that. Yes, KMPT do have, they're part of the transitions program. And you're right, children and young people, they're not always going to stay as, you know, young persons. They are going to transition, so it's important that we work hand in glove together. I think you asked me whether KMPT will be geared up to pick up the challenge, as it were. There will be challenges in terms of workforce, as I'm sure it's been talked about. I wasn't here at the start. But indeed, in terms of working with partners across the system, yeah, KMPT will play their part, and they will step up in terms of making sure that there is a continuity of care and that there's no disruption. And I can speak with some authority because I know that there is an active program around transitions programs with KMPT.
Can I just say thank you very much, Emma and Albert, for coming along, and James. We were a bit negative this evening, I understand that, but that's because of our concerns. But I'm sure working together and being focused, we can get this right. And I have every faith that James has done, because he's done some brilliant work for Medway, James, and I'm quite proud of what you've done, and I'm sure other members are. So thank you very much. And with that, I'll go over to Vice Chair.
Thank you, Chair. Yes, just reiterating your words, thank you to Albert and obviously Emma, and thank you to Councillors Cooper and Howcroft Scott for their input and their attendance this evening, and also for Lisa Scarrett for her work in what she's done as well. I do understand that the crisis paper is going to come back to us, and that you're happy for the report to go to the CYPONS, produce an accountability paper, and again come back to us. So with that in mind, Chair, I think that we move to note the developments today.
Chair, can I just ask what your new role is? Is that okay?
Yeah, absolutely, Councillor. Whilst I'm not here representing KMPT, I'm now in the CCG as the Director of System Collaboration. So I have taken over Karen Bembo, whom I know the committee knew very well. She's taken an earned retirement, so I've stepped into the breach, as it were. So I am barely 2 months into the role, so I'm still, yes, partly KMPT. Yeah.
Sorry, I thought I'd got a big enough mouth for you to hear anyway. Yeah, we move on to item number 6. Yeah, and you'd like to kick this off, would you, Victoria, please?
Yes, thank you, Chair.
Oh, we're going to have, yeah, all right, sorry, I've got Victoria down here. They're doing it to confuse me this evening, and they're doing...
Is it us? All right. Thank you, Chair. Thanks for inviting us back to this committee. I'm here. My name is Taps Mutikati, Director of System Collaboration for NHS Kent Clinical Commissioning Group, soon to be Integrated Care Board come 1st of July. So with me, I've got my able colleague. I'll let her introduce herself.
Hello, my name is Victoria Marshall, and I sit across KMPT and the CCG, and I lead the dementia programme. We're not here to confuse you with these multiple roles. This is about collaboration, it's all working together.
Thanks, Victoria. So hence the deliberate drop in my title of commissioning, because as the system matures, as it evolves, there is a greater need for us to collaborate. So that's the role that I now occupy. But I won't labor on that, Chair. So I take the paper as read, but the paper seeks and sets out at least 3 key areas in terms of an update, work that we are undertaking across the system. So it sets out our plan for community mental health transformation and how it directly impacts the Medway population. It also talks to the dementia transformation, hence I've got my colleague today, Victoria, to try and elaborate or answer any pertinent questions. We also cover what we're about to, well, we've started the process, but it's still early days in terms of the work we are undertaking around urgent and emergency mental health transformation. So this is us seeking to enhance the pathway and recognizing that we have had disparate services across our urgent and emergency mental health, but it's about how do we bring a truly defined pathway that benefits the patients and the residents of Medway. And lastly, we talked briefly about the Frank Lloyd plan, Frank Lloyd unit, where we're working with colleagues from Medway Foundation Trust to try and explore options in terms of how we could utilize that resource to give additional bed capacity to the Medway system. That's the broad outline of the paper, Chair, but we're quite happy to, I'm sure, take some questions.
Thank you, Chair. I was quite interested to read this report because I cared for my grandfather who had dementia until he passed away 6.5 years ago. So I know quite a little bit about dementia. I have 3 quick questions, Chairs, if I may. The first one I think may be best for you, Taps, which is page 82, talks about mental health together model being trailblazed in sites in Medway. I may have missed it, but I don't recall reading where those trailblazer sites are in Medway. So I'd just like to know where those service innovations are going to be based. And then perhaps my second 2 questions are more appropriate for Victoria, and they're more focused on dementia. The first of those 2s are data coding, something that I've come across in a entirely different field, working across government to ban virginity tests and hymenoplasty, is the problem in the hospital system and with GPs about data coding. But one thing I realised then is actually that problem was quite quickly fixed. It's very fixable. So I wanted to know a timescale on how quickly you think this problem with GP practices getting the correct data for dementia register can be fixed. And then my second question on the dementia, which is the thrust of my questioning this evening, is that it seems to me that the whole strategy about how we're going to improve diagnosis for people and access to services with those suffering with dementia in Medway, Chair, is with these 3 additional GPs who are based in Medway practices who have some kind of enhanced role. So my question is, I mean, I know, in being the Councillor of Princes Park, my number one problem, which is why we have the task group coming forward in the summer, is access to GP services. Are you confident that these 3 additional GP services are going to have, GPs are going to have the time to do this additional work stream? How much more advanced are there in terms of the rest of the GPs? Why, similar point to Councillor McDonald, aren't all GPs experts in dementia diagnosis? And is this going to be actually deliverable given both the national challenges we faced and the acute Kent and even further acute challenges that Medway face with GP shortages? Thank you, Chair.
Thank you, Councillor. Just as you asked the question, I thought I've got to remind myself where we've got the services. I know we've got at least 2 identified, Rochester and Chatham, but there are 4 areas that have been identified. The other 2 escape me at the moment, Councillor, but I will, during the course of this meeting, just dig up the other 2 sites. And the idea in terms of them being trailblazer sites, it is essentially a pilot which should inform us whether the core model that we've put together will work and will deliver. And the thinking there is that if it's successful, we are now starting to truly transform how community mental health works in the community. But in terms of your direct question about the other 2 sites, as I said, we've identified at least 4 sites. I know it definitely is Rochester and Chatham, but I'll just dig up during the course of this meeting and tell you the other 2 sites. And I think the other questions you wanted my colleague to respond to. Yeah, sure. Thank you.
Thank you. So your first was around the data coding. In order for a person to be put on the dementia register, they need to be appropriately coded within their own primary care practice. There is a variation currently, and we think it's around 1% of the dementia register across Kent and Medway. In order to address that, we're doing a number of things. Firstly, we're beginning to analyse data to identify those GP practices that look as though there's a significant variation, or in fact, the number of people on the dementia registers has reduced. For those practices, our dementia clinical leads are going in and they're supporting those practices to review their lists. There was a recent Medway example where a GP practice who was supporting care homes changed, and during that change and switchover, the dementia register dropped by 15%. The dementia clinical lead went in, looked at it, went through the patient records and managed to increase it back up by 18%. So found an additional 3%, which was great. So there is that very targeted work going on. The dementia clinical leads have also developed a new toolkit which enables GP practices to scrutinise their own systems and identify those people who are being provided with, or seem to be provided with, care for dementia using their medications, as an example. And then that we're asking GPs to review those lists. Now, there are advantages to the GPs for doing that. It means that their dementia registers are correct, and also that they are able to access the correct list of patients for annual reviews, which of course has a QOF payment attached to it. We have been promoting that now for a year, and certainly those GP practices that are doing it are finding it quite helpful. However, it's not a mandatory thing. So it is very much about us incentivising practices and raising the profile. The last thing we can potentially do, and we're seeking to do, is whereas we cannot run that data quality toolkit currently on a regional level, we are hoping to be able to do that in due course. There will be a consultation on access to patient data at some point during the summer. Once we come through that consultation, we hope to be able to run that extract, at which point, once again, our dementia clinical leads can go in and do that very targeted work in a very systematic way that we haven't had previously. So I hope that answers the question.
So when you say these dementia clinical leads, are you referring to these 3 additional GPs?
I'm not. We have 4 dementia clinical leads across the the CCG as it currently exists, one in each healthcare partnership, and they currently give potentially 2 days of their time per month to the system so that they can go and do targeted work with other GPs. It's peer support, if you like.
So these 3 additional new GPs,
Yes. Okay.
what are they doing? How are they going to improve dementia care for people in Medway?
Okay, so what we're specifically focusing here on within the paper is increasing diagnostic capacity. And the GPs with enhanced roles are not the only way of doing that, but to answer your question specifically, we'll start by focusing on them. So what they have done is they are finishing this month their training with Bradford University to basically be able to undertake a higher level of clinical assessment so that they can diagnose patients not with the most complex levels of dementia, but within that medium ground that would traditionally be referred into the memory assessment service. So these are people that your standard GP would not feel confident or comfortable diagnosing. These GPs are working alongside psychiatrists within the memory assessment service, so they have that peer support again should they come across anything that is unusual and they need some clinical support with. They are then able to provide those patients with a diagnosis with confidence, and that in essence increases our diagnostic capacity. The advantage of using GPs with enhanced roles is that we're very secondary care dominant in Kent and Medway at present. And the idea of having GPs with enhanced roles is they can provide that confidence to their peers as well, where there are lower levels of acuity. The other areas that we can increase diagnostic capacity, which are touched upon in the paper, include GPs that support care homes are able to use something called the Diadem tool. And these GPs with enhanced roles will be able to provide that peer support to encourage them to do so. I'm referring to them across the system as somewhat super GPs. They're going to be everywhere. As part of their training package, they were recruited to do this. They have had their training supported. They have undertaken to give us a commitment for at least the first year in terms of their capacity. In fact, they've doubled it in the last 6 months. So they will come out of training this month. They will then go through an accreditation process. They need to get a certain level of evidence behind them in order to be signed off by the GP training hub. But during that time, because they will be under the supervision of psychiatrists, they will already be able to support our secondary care provider to address those waiting lists that we already have.
If I may add, but I've got your answer as well. So I think what the GPs with enhanced roles, we are incredibly excited about this from our perspective. And the reason why we're excited about this is not only do we have a national sort of target to increase dementia diagnosis, but if we think about how we ought to release capacity from secondary care providers, in this case KMPT, and ensuring that other partners can undertake diagnosis, it's a shift in terms of how we are used to undertaking dementia diagnosis, because the sole provider of dementia diagnosis up until we started this transformational program was our secondary care provider, KMPT. So what we are doing, we are looking at other regions in terms of how they've enhanced their memory services. And if we get those 3 GPs to a position where they're competent and comfortable to undertake dementia diagnosis rates, it'll be a transformation that we haven't had in Medway, let alone across the county. In terms of, I guess, the other 2 sites, so there are 9 PCNs across Medway and Swale. Sorry, primary care networks. So the next, I talked about Rochester. The next one is Medway South. So this is a collection of GP practices who will be in Medway South. That's where we have the next pilot. And I'm going to speak, if you forgive me, the other one will be Sittingbourne Primary Care Network. So those are the 4 sites that we're going to do the trailblazing work on.
Chair, I find those answers quite reassuring particularly Victoria's answer about the idea of super GPs seeding understanding and training up their colleagues, and at the same time providing additional capacity with the secondary care pressures that we have at the moment. I can only say that I really hope it comes to fruition and that the plan works. Thank you.
Okay, thank you very much. And thank you, Taps and Victoria, and obviously we all wish you well in your new roles and hope that some of these things will improve in Medway. And I agree with much of what Councillor Lammas was saying, actually, about dementia diagnosis. My mum's got vascular dementia. She was diagnosed 11 years ago. She still manages at 93 to live very nearly independently with a huge amount of care, and things frequently go wrong. And what I would say about the dementia service is that once she was diagnosed, I don't think she heard from anybody for about 7 years. Perhaps it didn't matter all that much to my mum, because obviously she'd forgotten when she was diagnosed, and I don't mean that in a pejorative way. That is the situation. I've had occasion myself to call in the crisis team, and have to say I've not found it particularly helpful. You know, they give the same diagnosis every time: mild to moderate vascular dementia, lacks insight, doesn't take responsibility for her own actions. Actually, I might have been able to say that to myself about my mum about 40 years ago, before she was diagnosed with dementia. You know, sometimes, as I'm sure you know, it's sort of magnification of personality. That's a personal perspective. It isn't a service that works alongside people in any way at all. And, you know, actually, my own experience of my mum is a very small part of the case of dementia that I deal with. More often, I've got casework of people who can't cope with a relative, who haven't got the kind of resources that my family have got to scaffold what isn't available in the community, and are often absolutely desperate. And in particular, ethnic minority families often hold on until the very last minute and don't seek help and hit a very big crisis. So I would say that, you know, with the BU Medway here, I'm very pleased about the focus on the LGBTQ community, but I think there equally needs to be a big focus on the ethnic minority community, because in my ward, I've seen some pretty rough experiences amongst that community where they haven't known where to seek help, felt they couldn't seek help, and found themselves in terrible situations. So I think that needs increasing. And like Councillor Lammas, it's good to hear about some specialist GPs. But all of the things that we say we do come down to whether or not you can get your relative with dementia down to the cafe for a couple of hours a week. And if you can't, bad luck. If you want to go to a day centre, you've got to actually be pretty comfortably off these days to be able to access it. So I'm afraid these things are not in place. They need an enormous amount of work. We had a task group ourselves, you know, a big push for dementia-friendly sort of, you know, parts of the community, and lots of training. Obviously, the pandemic has done its work in eroding a lot of what was there. A lot of the voluntary groups don't exist. And you know, when I visited the Dementia Cafe in my ward, one of the things that people said to me most were the relatives there saying, well, yeah, you know, here I am. Okay, you know, Dad's over there having a lovely time. I'm here having to get 3 hours off work to bring him. So, you know, access to those kinds of things, the dementia services working alongside the deterioration sort of cycle, that all needs, in my view, a lot of work, but maybe these new GPs will certainly help people being newly diagnosed. That's the first thing. So that, you know, I'd like to hear whether you think that particular situation is going to change. On the safe haven, Is that open every day and all day? And it says that the Haven works closely with GPs, community mental health teams and crisis teams. When I've raised that in the Rochester PCN, which I am invited to come along to sometimes, although it hasn't met for a good while for various reasons, their view of it was, well, yeah, it's closed a lot of the time, and it's all very well to say it's a walk-in service, but it depends what time you walk in. So I'd like to know about that. I can see they're offering virtual consultations, but, you know, that's part of the picture everywhere. Similarly, with talking therapies, massive waiting lists, and it seems to me that people go around the track. They have talking therapies, finish, and go back again. Is that a good thing or not? I don't know how you feel about it. Something that I feel very positive about is this Medway Primary Care Mental Health Team. But I'd like to, we've had a short discussion about this at this committee before, and one of the things that was said was that actually when members of the team, individual members of the team, were trying to find a spot where they could actually work in the PCNs, they couldn't find any physical space to go. And I've mentioned before, members of the committee will know the lack of a premises strategy by the CCG, whether the ICP have got one, of course, remains in the lap. But I do see that as a barrier to this kind of co-production, co-working, actually, you know, getting these teams. Because to me, ideally, the GP could be bypassed completely. You know, if someone can do a good digital or telephone triage, then the person who's, you know, got a mental health problem should be really going straight to that team. I think that would help. It would unburden GPs who are not specialists in this area a great deal, but I don't know what the situation for those people are. Got some great groups here who do wonderful work in the community, but I think those groups could probably all do with more support from the primary care mental health team, because very often non-specialist people are left coping with people who come along to what they can offer. And apart from signposting, you know, sometimes can't do very much to help somebody who's in a crisis, valuable in the extreme those situations are. So I'd like to hear from you about all of those things.
So if I answer the question specifically relating to dementia, and then TAPS can pick up the others. So your first point was around what we perceive to be the drop-off post-diagnostic in terms of the support that people get from health services. You'll see within the paper that we talk about the new dementia coordinators. Last year we piloted 3 sites in Medway, and as of April we've had 9 sites go live across the area. The dementia coordinators are very much focused on that front end of the dementia pathway, that concept that once the individual or their families identify there's an issue within primary care, a referral not only goes to memory assessment but also to these dementia coordinators, so pre-diagnosis, so we can start to understand the family situation and actually put in some support. In part that recognises that not everyone wants a dementia diagnosis or may want to delay that journey, so it gives them support up front. The idea is then that they will support the individual to access the diagnosis and the families, because we recognise it's a very difficult transition for everyone to make. And that when then the secondary care services have finished and have supported the family to the extent that they can, they then hand back to the dementia coordinator who puts in place a support plan. Now there's already a opportunity for GPs to offer an annual review to people with dementia. The idea of having dementia coordinators provide a support plan is it feeds into that and it makes it easier for everyone, including those in primary care. It enables the patient to only tell their story, the person to only tell their story once. 20 years in the NHS, I apologise. And it offers this opportunity for those families when there are issues that perhaps crop up as time progresses, whether that be the person goes into crisis, there's a deterioration, perhaps there's family support needed to be put in place, to actually have one number to call where they know that person, they already have that relationship, don't have to retell the story, and the dementia coordinator can then put them in contact with services. They're the glue that's going to hold together the pathway, we hope. Now, they're very new, and we're only just beginning to evaluate the first pilot sites that went through. As part of that, one of the things we're looking at is what services were they able to signpost and support the person to access, or to put it another way, what's missing? This year, we're working with somebody, I'm not sure whether you know them, they're the Applied Research Collaborative. They work across Kent, Surrey, Sussex, and we've put in a bid for us to actually evaluate the Dementia Coordinator service so that we're actually able to do some of that detailed mapping and make sure these services work correctly. So I'm quite excited about them. I think whoever you speak to is quite excited about them at the moment. The risk is they will become the answer to all of our issues with the dementia pathway, but we're genuinely hoping is that they're the first point of contact for patients, and I hope that helps reassure you to some extent that we're trying to alleviate that drop-off that I think unfortunately you've experienced. Then you were talking about access to support during crisis. Now, last year there was a lot of work done, a lot of consultation done with people across Kent and Medway in terms of what good crisis support looks like. And we were able to identify 4 principles, and those are support for people transitioning between services, particularly from hospital back into a residence of some kind, support for people in their own homes, support for people in care homes, and step up, step down beds as and when they're required. Now, we're working with each of the healthcare partnerships to identify what's needed on a local footprint, because to be quite frank, the Ageing Well agenda has come into being. There's lots of really good work going on the ground, but we need to understand what's actually available in Medway against each of those 4 principles. Medway Council's very engaged, and we're hoping that we're going to be able to pick up a solution that works very much for Medway. That is linked, of course, to the Frank Lloyd discussion as well, particularly around step-up, step-down beds. Thank you.
Thanks, Victoria. Councillor, I think you asked the question around safe havens in terms of whether or not it's open all day, every day. It's not open all day, every day. It's a real issue for us at the moment, and the police have also been voicing their concerns in terms of we know that majority of the Section 136 conversions tend to take place late at night, and safe havens won't be open. Now, as I said earlier, in terms of the urgent and emergency mental health transformation work, it's in its embryonic stage at the moment. We recognize that the pathway is not fully defined because that means if it's not open, safe haven, around late at night, it means that the pressure is going to be seen at the front door of A&E, or it will be seen at KMPT's support and signposts sometimes. So what we are seeking to do, and there's an opportunity for us at the moment, which it is commercially sensitive, of course, but the contract is about to expire. So it presents us with an opportunity to look at the entire pathway and decide whether we ought to, reconfigure or change how that service works. I'm being a bit hesitant because, as I said, it's commercially sensitive. Because what we want to do is to make sure that there's no wrong door, a bit like what we're trying to see happen within our community mental health transformational work. So if we are hearing the noises and the complaints about we can't access a service and we've got an opportunity to review the service, we are taking that opportunity now. I guess that's all I can say at the moment, but we are aware of that scenario, Councillor, so it's not being ignored. We will be addressing that as part of the wider urgent and emergency mental health transformational program. I think you also asked the question around, I think it was talking therapies in terms of what's being done. So I'm not an authority figure on that sort of subject, I've got to add, but I'll take that back and just make sure that we give you an update specifically around talking therapies and what we are trying to do. But what I can say is our IAP services are also going through a process. It's been signed off by the board. We'll be going out for procurement exercise in autumn. The service spec is well defined in terms of what we are after to try and enhance those services across the board. But as the specific question around talking therapies, I would want to come back to you with a meaningful response, if I may.
So there was just then the location for the primary care mental health team, how they are actually going to be placed within the primary care networks.
So the primary care mental health teams, the location, I couldn't give you the exact location, I'm afraid, at the moment. I think this is a reflection of me being new to the role and needing to understand the full brief. I take it you're referring to the rooms that we've talked about as part of our core model. Yeah, the locations, I think, once we are clearer on that, I will again keep you updated. But the view is that you've got to have a room where you have the entire sort of core model workforce working in one place. But it'll be closer to the Medway sort of residence, but I don't know the location at the moment, but I'll come back to you on that.
And just come back on that, Chair. I mean, I don't know how helpful I think that is. You know, what seemed to be envisaged at first, because this is not new to the ICP, is that, you know, and this desirable vision is mooted a great deal of a GP practice being a place where lots of practitioners can work, so that everybody doesn't just see the GP. In fact, that, you know, triaging and other methods of deciding where people are best placed can be used to get them to that place quickly. If they're going to be located in one place, then that still puts the onus on the GP, the non-specialist GP, to make a decision about trying to get them there. And I don't know how useful that is or how that contributes to a vision that has been promulgated a great deal, and indeed is presented. I mean, Victoria, you said that Medway is secondary care focused. Yes, I agree with you, and the reason for that is because primary care is so weak. You know, that's why everybody goes to the acute hospital, and they don't just go there to have a procedure. I'm sure if you went there, the queue is out of the building and round again. It's like a giant GP surgery, because people can't get GP appointments, and that, I'm afraid, is a very real issue. And I've heard your sort of predecessors in this meeting say, yes, we all know that primary care in Medway is terribly fragile. And I don't think it's going to be strengthened anytime soon if this sort of co-practitioner model ends up wanting their own space where they all have to stay together to deliver a model. You know, initially, I can see the desirability of that, but going forward, that seems to mitigate against everything I've heard for about the last 5 years. So, okay, you know, maybe that's how things are going to be, but that involves then people doing what everybody has in the past said isn't desirable, going to another place to get a particular sort of treatment, having hopefully been signposted there by the GP, who often isn't in a position either to see them at all or to signpost them anyway. So I feel fearful at the moment that having that extremely, you know, desirable team isn't going to work if they're not out amongst the primary care networks trying to take a bit of the pressure off. And I don't think, well, we'll see what we say in the task group, it will attract GPs here if they find that that's the situation.
Sorry, if I may just quickly respond to that, Councillor. I'm just want to check my understanding. You're asking about primary care impact at the back of the core model. which is the community mental health transformation. Is that right? Sure. Yeah. So as I said, there are 4 identified pilot sites, but I couldn't give you the specifics within a given footprint of a PCN. Now, my team have been engaging with the local GPs to understand their pressures and just to make sure that all the concerns you've raised around choking capacity, location, room space, that we address in those issues. So they're being taken into account. So it's a joint collective effort. I think the paper also talks to how we've been informed in terms of the model, in terms of the engagement exercise and processes, that we've worked very closely with patients and people from Medway with lived experience in terms of opportunities to redesign some of these services. I am confident that the team would have captured some of the concerns you've raised, but in terms of giving you the specifics in terms of location and for you to gain an understanding and appreciation of, is it going to have a material adverse impact or not, I would have to ask my colleagues about which sites exactly we've got identified. But I am confident, as the paper sets out to some degree, that we have been engaging with the right parties to make sure that we've got the right place and take into account how patients will access service, how they'll get to those places. And what COVID has taught all of us, not just in primary care, but all us who have been in mental health, is we will have to retain the different mediums in terms of assessments, be they remote or face-to-face. Who knows what autumn is going to bring in terms of COVID. So we need to be prepared in terms of utilization of digital tools. But as I said, we will indeed give you some specifics in terms of sites, just to help you gain a better understanding.
Look, I haven't got a problem with different forms of assessment. I understand that some people don't feel comfortable, but I can't see a way out of that, partly for, sort of trying to build resilience against another pandemic, and partly because people have got used to that way of working, quite frankly, and they've got to do it. This is about this idea that the GP is not the be-all, end-all of everything, that people don't focus only on trying to get an appointment with their doctor, but they can have some confidence that they can see another practitioner who will help them as much as they expect that their GP might. And at the moment, that isn't happening, and it won't happen if you put together a new team and they're just sort of somewhere else. It just won't. And maybe the answer to that is give up saying it then, and, go to a model where, okay, you have to go there if you want mental health, there if you've got a funny foot, over here if you've got some sort of, perhaps that is a better way of saying it. Maybe that it's just to sort of clear the decks and there it is then. The initial assessment will be digital and you'll be sent somewhere and you might never go to your GP surgery, and co-location of practitioners in the GP surgery isn't a reality. I don't know. But at the moment, that is your narrative. That is the narrative of the CCG, and it has been for the last at least 5 years. And the fragility of Medway's primary care scene has been accepted, and that's been posed as a solution. If the ICP is going to do something different, all well and good. Just one more plea then, and that is, it would be good to tell the police that these places, I know the PCSOs in my ward have tried to send people there, including taking someone to the McKenney Centre and finding that it was shut and then being stuck with them and not having, either the professional expertise or the time or the support to cope with them, but finding that they have to. That's how people get sectioned, very, very quickly, because there just doesn't seem to be an alternative. So I think, the more that message can be communicated until it changes, that will certainly help community police. Thanks,
Councillor Murray. I we'll take some of the primary care concerns that you've outlined to my other colleagues who cover primary care. But what my response was trying to talk to the primary care mental health and what we're trying to do with the secondary mental health community teams, which you're right. We don't know what the final outcome would be, but I think it's important that we do the pilots, because the pilots will tell us what model works, and there'll be a proper evaluation process from a mental health perspective. But the wider points around primary care, I will indeed share those with my colleague, who's a director in primary care, Suk, and Caroline, my line manager. I'll take that back. Your plea around, please do liaise and let's discuss with the police, absolutely. And the opportunity as well with the Integrated Care Board is Medway Council will be represented at the Integrated Care Board. It talks about this in the paper as well, that from a mental health perspective, there is a newly formed provider collaborative where we've got representation from Medway local authority. So I think there are different avenues, if I may say so, where these conversations will be captured, conversations will be scrutinized, and I'll be happy to come back to this group again once we've gone through the review, given the commercial sensitivities about what the plan truly is.
Yes, please, Chair, and I will keep it brief. I will be positive and say that it's good to see this transformation, because so I will start positive and then and then go downhill slightly, because actually what's there now isn't good enough. You know, our inboxes are full of people. Jackie will know I've dealt with a case just recently which was horrendous, and horrendous for the family, because if the diagnosis isn't there, even though it's clear, they're in like limbo. There's no support anywhere. They're almost waiting for that diagnosis before anyone would do anything, unless there's crisis or they ended up in hospital or they've gone wandering. But for the family, it's horrendous, that is. I will talk about the free GPs. I'm not going to get overexcited about, because, you know, 10 GPs across Kent and Medway, although it's a start, it isn't good enough, is it, really? We need more. And it doesn't have to be, like Councillor Murray said, just GPs that are experts. It doesn't just have to be them, you know, to do that. And I will say, I know we've changed, even though we, from the risk of the performance report later on, we seem to be scrapping COVID out of everything. But I know we are talking about COVID still. But, you know, try telling, I'm going to be careful now because some members will kill me. Try telling our older residents that really haven't got to grips with technology. I've got a one now that is trying to deal with his wife. They're of an older age. And one may be okay, but the other one's screaming and shouting in the background. To do a remote GP call isn't easy. It isn't easy with someone with dementia. So something needs to be put in place there. It's hard work. And I will say about the comment you made about now, we keep being told, and I'm going to try and be excited about the integrated. Well, I'm going to try, but we had our own CCG in Medway, and we were promised everything and didn't get hardly a lot for some of our services. So just some questions here, just quickly. So the Admiral Nursing, I know, do an amazing job. However, I just sat in, and I'm not going to report on the person, I just sat in on one of those meetings with the person I told you, with a resident, and the first words out of their mouth was, we're overloaded. We can't cope. We're going to try and help you, but we're struggling. So what are you going to do to support the Admiral Nursing team? The significant investment, one thing I will ask, Chair, and members around is that when we see these papers, instead of significant investment in Kent and Medway with a figure, I would like to know, and not for now, you may not be able to tell me now, but what is the significant investment in Medway for dementia services? What extra are we getting in Medway? So that's what I would like, and it isn't, you may have the figure to hand, but you may not, but I would like that, please, Chair, as an action, because I want to start seeing what Medway's getting. Even though we should all be interested in our family across the border in Kent, I want to know what we're getting extra. The memory assessment has been a disaster up until now. The waiting lists have been horrendous. I would like to know what significant change you're going to make with the pathway, and how are you going to guarantee, because you're almost guaranteeing in this report that everybody that goes to that wants that assessment are going to get it within 6 weeks. And what happens if they don't? So what's going to be the outcome for them people that are waiting 9, 10, 12 weeks for that assessment? I always throw the training one in because I think it's important how we're going to train the wider audiences, those not just the GPs, but the social workers, the hospital, you know, how we're going to do a bit more training, including community ambassadors. And I'm going to touch on the last point. We had a fantastic Dementia Alliance here in Medway, Dementia Alliance, that was here about 4 or 5 days a week. Now we sort of get it on a Monday, we get a load of emails because they don't have resource or capacity to do anything else. We pulled the resource on that. And I think exactly what Councillor Murray said, we need to actually build that up again, because all of those community ambassadors, those almost family experts that you've got that have lived this, they've got a lived experience of dealing with people with dementia. They are the people that the carers and sufferers could be talking to. But there's ad hoc groups set up, but there isn't we pulled all of our resource because we didn't want to pay the National Dementia Alliance any money. So again, is there anything you're going to do with those? I can remind you of the questions if you want to come back.
I think I may need you to, but I'll start and if I've missed anything, please do let me know. So to start with the Admiral Nursing Service, I absolutely agree they're very much valued. Now, when we talk about reviewing the Admiral Nursing Service, we're actually talking about giving the Admiral nurses space to tell us what they need. Now, we haven't got to the end of that yet, but some of the key themes that are coming out are leadership and that opportunity to be able to engage in some of this other work that's going on so that they can improve, I don't want to get too technical, so that they can improve their relationships with other services so they don't take on all the burden themselves. I'm going to include the dementia coordinators in that conversation, because if they can see those people that perhaps don't need an Admiral nurse, those families that can be contained by somebody at that lower level, it releases the Admiral nurses to go and do that more complex work with families. The other theme that we're hearing is actually they need more support in terms of administration, some of those things that don't enable them. So we're currently looking at that with them. Does that answer that question? Oh, brilliant, superb, okay. In terms of the 3 GPs, I agree, don't get overexcited about them. They're not going to solve all our problems. I am excited about them, but that's not all we're doing. So we have advanced clinical practitioners coming online. So these are nurses who have taken additional qualifications and been supervised for a number of years to be able to give a dementia diagnosis. Again, it's not going to be the very complex cases, but it does improve the capacity in order for the service to manage that caseload with more ease. We're also looking at, and the paper refers to something called the EMAIS service. So the concept here is that traditionally, just because of the way the service was set up, we've seen people on a 2-step process. You go in, you are assessed, and then you come back another day and you get your diagnosis. And somewhere within that, you'll have your imaging. Not everyone will be eligible for that, but, bear with me. The new process is that for some people where it is appropriate for them and they want to have it, if they already have the imaging or if they don't need the imaging because their dementia is very evident, there's an opportunity for them to go in, have an assessment and a diagnosis given on the same day. Now, that will reduce the waiting time. It's not going to guarantee it for everyone, nor is it appropriate for that to happen. There will be some patients who have a complex dementia diagnosis coming, and they might need multiple imaging in order to do comparative studies. It may be more appropriate for them to wait longer. Equally, there may be some people that it's a big thing, and they might just need longer to be able to come to terms with that, as opposed to have a one-stop shop, if you like. So we're not going to guarantee it for everyone, because actually there's a certain element of appropriateness and of patient choice within there. But things must improve, and we absolutely agree with that. So we're going to try everything we can in order to improve the memory assessment service. And I think the guarantee I can give you is that it's on everyone's radar. So this the the provider collaborative that sits within the ICB, it's one of their key priorities. For KMPT, who run the memory assessment service, it's also one of theirs. So you've got all of these organisations coming together now to focus, and I hope to see significant improvements.
So sorry, Chair. So Victoria, I mean, in the report, you're saying within 6 weeks.
Mm-hmm.
So are we saying here, right now, because it's a lot longer, as we know, for some people now, a lot longer, actually, are we saying that we are guaranteeing less than 6 weeks from now on, when this comes in place soon, are we saying, because it says it here, you will bring it under 6 weeks for the waiting time?
There is a transition time that we're going to have to bring into effect because we've got a waiting list to deal with as well.
Of course.
But the system ambition is to reduce the waiting time to within 6 weeks.
From when are we looking at from this transformation time?
We're not at that point yet because we have to deal with the backlog waiting list. But I think that that's something we can bring back to you in due course.
So what's the current waiting list of the, just if you do
So
know, or roughly?
In Medway, it's circa 300 people that are sitting on the waiting list.
Okay. So, okay. And the significant investment and also the Dementia Alliance. Significant investment, I suppose that'd be you, Taps.
Yes, that'll be me. I haven't got the breakdown, but indeed we'll bring the breakdown to this committee. Chair, if we may, please, we'll take that action. I just wanted to talk to, I guess, some of what Victoria was touching on, if I may, Councillor. I know that we are after the exact date when we should see this target come into play. I think it's important, if I may, just to say we need to see how the Enhanced Memory Assessment Service clinic is being run within KMPT, and then we'll gain some confidence, and we have a reference point to tell us, when we're likely to roll it out across the board. The waiting list, whilst is poor and something that we are not proud of, but we're doing something towards denting that, is it's also being compounded by the fact that our loved ones are old age patients and people. During the height of the pandemic, they were not accessing services, quite rightly, and we understand why that was the case. So that has contributed, obviously, to the growing waiting list. But as Victoria's quite rightly touched on, it's everyone's business at the moment, from KMPT all the way to the CCG, and within the Provider Collaborative Board, which sits under the Integrated Care Board, it's an item that is high priority, and we need to make sure that we sort out the waiting list first, and then we can come here confidently saying, we are now seeing a majority of the patients within 6 weeks from referral to diagnosis. I think that will be a milestone for Medway and if I may say so, Kent and Medway as a whole. So I just thought that answers or complements Victoria's point.
Chair, can I just come back just quickly on that? I do agree with you, but I do think from the board, maybe not for now, but I really do feel that when you get a report and you start to get excited about it, we had it in the last one as well, sometimes you must have your priorities you're working to, or you're building that now. There will come a point, Chair, maybe we can have a target around when you are looking to transform. Because we've had it before, haven't we, with the fourth or fifth transformation of the CCG over its years, where we're told it's transforming. I don't want to be 5 years down the line and you're still transforming, because that's not helping our patients. I mean, it is really good. If it comes together, it'd be great, because we need to. It's one of the biggest things for our community. But I just feel I don't want it just to be a vision, because this report is almost telling me it's going to be an action that you're going to make happen. I don't want to be just now feeling that it may happen. But that's my... and also just the Dementia Alliance to finish with. I don't know whether, James, you want to... Because I know it was supported by the Council and the CCG. I don't know what happened with that. Because my question around the Dementia Alliance, as Wendy knows, as Dementia Champions and everything else, was it done significant work to support our community and actually created community ambassadors, people with knowledge, and the funding was just whipped away. And is anyone, the new board or anyone thinking about bringing this back?
Thank you, Chair. So I think the question is that we've moved on. So we've now got the Non-Visible Disability Alliance and a programme of work around that. So we brought together a number of organisations. That's chaired, I think you're aware, by people with, whether it's dementia, because it's a number of different organisations in that particular piece. And probably what might be more useful is a briefing note to members just setting out where we are, because we've just moved on from one single organisation to try to recognise dementia clearly in its own aspects, but they're actually part of a broader arrangement, just as you've said, Dan, to make sure that we don't miss out in terms of inclusivity. But probably a briefing paper might be useful, Chair, just for members to know where we are.
Yeah, because that was something that we had when we... remark, but Safe Haven, and they might have changed it now, but if you go around there in the dark, please believe me, it doesn't feel very safe. And I took somebody around there in the dark and I didn't feel very safe. So they might put some more lighting on, who knows. Okay.
Thank you, Chair. Yeah. Thanks to Victoria and Taps for their input today and coming along. Obviously, we're looking at significant figures in Medway, not Kent and Medway if we can, and obviously the briefing paper that James was talking about. So I move that we note the progress update in this report, and also agree that regular updates on Kent and Medway's mental health and dementia improvement programme to continue to be brought for information and discussion to this committee.
By the request of my coordinator, he's asked for a 5-minute break, and I don't think I can refuse him. I might have anybody else, but I won't refuse Michael. Okay? So we've got a 5-minute break.
ensure that adults at risk are safeguarded. And effectively, realistically, we need to look at what we need to do to improve in preparation for the CQC assurance reviews of adult social care. We asked the LGA peer reviewers to focus on the following areas, so our care pathway, quality of practice. We'd had an LGO complaint response and we suggested that the peer reviewers looked at that so that we could assure the LGO in what we were doing. Our resources, are they appropriate? The structure of our safeguarding hubs and whether the Medway Safeguarding Adults Exec group is needed. The peer reviewers summarised their findings in the following areas, so leadership, quality of practice, structure and resources, performance and partnerships. And members of the committee are provided with full details of the report in Appendix 1 and then the action plan that we've developed in Appendix 2. So any questions at all?
Thank you, Chair. It's the first time I've read a peer review of this nature, so maybe they are quite critical. But my reading of it was quite critical. And so my question is simple, really. It describes a postcode lottery of hubs, and basically you should do away with the 3 hubs and have 1. So do you agree with the thrust of their review, and how hopeful are you that things will improve? Thank you, Chair.
Sorry, changing my glasses is the only way I can see. So, I mean, the review itself is, you know, the feedback that they've given is critical, as in a critical friend. So it's not in the same way as Ofsted do an inspection. It's suggestions that they make and recommendations about how do we move forward if that's the right thing to do for Medway. When they gave us feedback, actually, in the meeting, it was actually quite a mixed approach. So some of the things that they fed back were very positive. You know, particularly, I would suggest around the teams themselves, knowledge and understanding. I think what's happened, in my opinion and Leanne's opinion, is that things have become quite segmented, and that 3-hub approach was put in place. So for those of you that don't know, adult social care work in what we call a locality model. So it aligns with the PCNs that TAPS was talking about earlier on. So in different areas. And the hubs were put in place so that actually you could, if you lived in Gillingham, for example, you would always go through that right route. What that's actually done, we've seen, is created some pressures, because from a resource implication, if you get somebody that goes off sick and somebody's on holiday, you're left with a very limited resource. So we're actually reviewing that at the moment with a view to, is the 1 hub the right approach? The general feel is that it is, but what we're doing is some data analysis first, because we know that there are significant pressures in locality 1, that's where Medway Hospital sits. So any safeguarding that's raised at the hospital has to come through to adult social care. So we're just looking at the data to make sure that whatever we do is right. And actually those conversations have been taking place this week.
I mean, I don't take the view that it was a terrible review, actually. I thought it was quite fair. And I think you probably did as well. And I think it was a good thing for you and Leanne to bring in the peers. I think that probably was helpful, and it in any circumstances it's always useful. And I guess the thing about, you know, the LGA, it is a critical friend as opposed to a regulator, and that sometimes can, you know, elicit more frank conversations than you would have with a regulator. And obviously you've got to learn to be regulator focused anyway. And there'd been probably 2 waves of initiatives anyway, hadn't there, before, you know, one that was meant to sort of stop segmentation and push people into, if you like, a more generalist kind of environment, and then another that was focused on that sort of 3 conversations, you know, that Chris introduced. And I guess what's left is you know, probably requires streamlining, doesn't it? Because there were those 2, there were those 2 waves. And I think from the point of view of the public, the kind of locality language isn't very helpful. People don't really understand what it is, and the staff, you know, we were just talking, I attended a social care best interest meeting, and And actually, probably about half of the people there were saying, sorry, what you on about locality, that, you know, so in a way that the professional language can do with changing and streamlining, and I think that's useful. And obviously you've got off to a good start with putting some of the actions in place, some of which I know you're already doing anyway. What I wanted to ask about on this occasion, because I think it was, you know, an inherently useful and good thing to do regardless of the outcomes, was really why some of the things haven't been started, because the deadline for starting them is August, and there's still quite a few things on there that you'll have to get started in the next couple of months, when I think, you know, there isn't any more a downtime, is there? We have a summer pressure and a winter pressure and an autumn pressure, and I think that all of that. So that's my first question. You know, some of the things need starting soon, and that they haven't been started, and I wonder how you feel about capacity for doing that, particularly in terms of leadership. And the one I wanted particularly to look at was the supervision audit, because, of course, in children's services, supervision of caseloads has really brought down the sort of inspection narrative. And if that's going to happen again with cases in adult services, that's, you know, the good work will get lost, won't it? And it'll be seen to be that nobody's got a grip on the way cases are being managed. And, you know, I know the deadline for doing that is January 2023, but if it needs doing now, the supervision backlog is only going to build up, and by the time the new regulations come in, particularly with the new social work standards, I think it might be quite hard to give as good a picture as we can, because I think the case supervision is quite good, but there's a lot of agency staff, and I know that makes it harder to sort of run supervisions. And if we're going to have a regulator, there's a need to tie down a system, isn't there? Otherwise we'll end up in the same way that we sort of found ourselves with children's services.
Thank you, Councillor Murray. So with regard to just going to reflect on the locality language, because I need to. I get very frustrated by it, and I read case notes where we talk about, I've had a conversation with somebody, and actually what they mean is they've done an assessment because they're using the 3 conversation model, and I think that becomes a real challenge for people, because they don't know what that means. So I absolutely agree that we need to do something about that, so I just wanted to reflect on that. With regard to some of these not being started, some of them are very valid reasons. So when you'll see on here that we have a head of locality services at the moment, that post is vacant. We are going through the recruitment process. We've interviewed a few times with no success, so I'm revisiting the role. We've recently appointed, well not recently, it's 3 months now, but appointed a dedicated principal social worker in adult social care who knows Medway, worked here previously, has moved out of area, come back with a real passion to make changes. And so although in this document it says some things haven't started, actually in the last few weeks they have.
Okay.
Not all of them, I hasten to add, but they have. And if I just say that we've got this plan, we've got the adult social care strategy, which has an action plan, and we've also got a transformation and improvement programme. What we're doing is pulling all of that together into one plan in a similar vein to children's services, so that we make sure that we're not missing anything. So that's going on at the moment. There will be challenges from a resource perspective, you know, in the same way as children's services. You said earlier on about locums and so on and so forth, and we do struggle to recruit. That is a national thing, not just Medway. It is similar in adult social care and children's, unfortunately, that we're seeing that from a national perspective. So we are currently working with our HR colleagues to look at how we can put more information out, make it more friendly, because I think if you look at the role of children's and how they advertise and so on and so forth, that's very different to how adults has been. So we're sort of looking at how we can replicate that. I think with regard to the supervision audits, so if I just touch on the caseloads, Caseloads in adult social care are significantly higher than children's services. We are looking at some regions between, some people have got around 50 at the moment. Leanne and I have put a target in to get down to 25. We want to get to an allocated social work model as well. So at the moment, if I contact you, I might see James as a social worker 1 week, 8 weeks later you come back and it will be somebody else, and we need to get away from that, and that's one of the things that we get complaints about quite regularly because there's no consistency. So the supervision audits, an audit was put in place, but with the feedback from the teams was it felt like a bit of a tick box exercise, so that's being revisited. Actually, I've seen some very good supervisions recently on cases, but it isn't enough. It needs to be in that same format as children's services, and I think that they take place, but because they're not necessarily recorded in the right area, that's something that we've got to work on. But it is definitely that safe space for a social worker or a social care officer to have a conversation with their manager and really talk those things through. And then just so that you also know, Michelle Horlock, who's the principal social worker, has introduced what she's calling reflective super work sessions with teams. We were talking about transitions earlier on. The transitions team sits in adult social care for social care between children and adults, and they deal with some of the really most complex young people that are moving into adult social care. And so actually she's meeting with them as a group to so they haven't just got that social work to manager role, they're having those discussions as teams, and we're looking at how we can roll that out across the division.
Okay, thank you.
Thank you, Chair. Yes, so for agenda item 7, I move that we note the findings on the report and the action plans and the timescales.
No, doing the risk register.
Okay, lovely. So the next agenda item is around performance and risk for Q4 of 21-22. As the committee knows, it's the report and appendices summarise how we performed in Q4, and it also presents the review of strategic risks. We normally just concentrate on any ambers and reds. But obviously, if there's any questions for anything else, then James and I will be able to comment. Thank you.
Well, first of all, and Jackie, I don't think this is particularly for you, but it's exercised all of us. We're wondering why another pandemic has been taken off. It seems to have been deleted. And James, we've had conversations about the fact that the risk of COVID, before we had COVID, wasn't on the risk register, even though it was, if you like, known about and expected. So that's my first question. And I think, other than that, it is fair to say that given the situation with workforce, with huge pressure from the hospital to get discharges done more quickly, the Directorate is holding up pretty well in terms of performance to only have 14% in red. We'd all like it to be 0, but given the sort of pressure that the Directorate has been on, and I think that's going to get worse, because if the price of fuel continues to rise, domiciliary care is, well, unless something changes drastically, it's going to be very difficult for some of those workers. The cost of a tank of petrol is more than many of them earn in a day. So I think there will have to be some sort of national view on how that's tackled, because it's going to make, well, it will affect everything, won't it? It'll affect the detox as well, because those people won't be there as much as many of them want to be. They don't get travel support, most of them, from the companies that they work for, and they often get forgotten. But that's going to be a real issue, and I think that's coming down the track, and it will affect some of these targets. But at the moment, I think that the Directorate is doing well to hold up in terms of performance. But in the Labour group, we'd like to know what's happened to the threat of another pandemic.
Thank you, Chair. And so the key thing there is that the recognition that there may well be another incident such as the one that we've just gone through and to be fair is still living with. It's just the change in the emphasis so that rather than us not being prepared for it, we actually are more likely to be prepared because we're learning from the issues that went before. So it's a national change. There's a piece of work being moved through with the UK Health Security Agency that's working with local authorities. I'm on this steering group, and they're rejigging the whole of the system, and also on the back of the public inquiry that's shortly going to be released into the system, because clearly that's the work. The findings of that will help to inform it. So the recognition isn't that we're not suggesting that there may well not be another thing that we need to respond to. It's just suggesting actually that because we've been through that process, we've been able to rejig our system so that the local authority on its own, because that was a specific ask, or the risk as I understood it, is more prepared to respond to a pandemic as opposed to the fact that we're not aware that something will happen and we won't have mitigation in place. So that in essence is the reason why we've downgraded that particular risk, because we're not saying that it isn't unlikely, we're saying that actually we've got a system and we're more able to respond.
Yeah, I can't really buy into that, I don't think, James. It's a risk register, and what you've just said could equally well apply to cybersecurity, couldn't it? You could say, well, we all know about it, we've put loads of protections in, everybody's cyber secure aware, and therefore, if it happens, well, we'd all know what to do. That's a kind of development of the culture of the organisation, but it's not, to me, a kind of mitigation of risk. And I think, the risk register is there to alert us to the consequences if something goes wrong. And if COVID isn't on the risk register because we think we know about it, and by the way, I don't think we do know everything about it, then, you could say, well, we won't have a risk register because everything, we know all about all these things on there we've worked on and everyone's aware and it's all getting better. I understand the national push to do it, and as someone who isn't particularly a conspiracy theorist, I do think there's an economic argument for trying to push it away, actually, because of the state of the economy. But I would prefer it if we could find some way locally of keeping it uppermost in people's minds. I mean, I remember when we were worried about SARS, and we had all sorts of big training sessions and all the rest of it, and it stayed on the risk register for about 10 years, even though actually we never did quite get it. We've actually had a COVID pandemic, and now are living through the fallout. So I feel that is a risky business, to coin a phrase, I'm afraid.
So I think the distinction is that the way in which we manage any kind of threats is based on, as you've just said there, the risks and the likelihoods and the impacts. So because of the way in which we've changed to business as usual, our COVID response, and I don't bring into this committee the challenges that we have around managing other infectious diseases, whether it's TB or Legionella or anything like that. And because we've got a system that is able to respond. So the reassurance is we've got a health protection board, so we've moved having to have a standalone committee around COVID. We brought all of that work into the way in which we do things around here around infectious disease control. I receive daily briefings today on infections and outbreaks, and I risk assess where we are in relation to that, and be assured, members, that we haven't had any outbreaks in any event of COVID in any of our residential homes or anything like that for at least 3 weeks, if not longer. So the context of that, we've got ongoing surveillance. So I just want to reassure you, it's not about that we don't, I'm not feeling that there is a likelihood that something might happen. It's just that we will deal with it now in the way in which we would deal with any other outbreak. So if there was something that arose, there's a process that we do. We initiate a plan. We have got a plan for that, and the plan has been updated. So just reassurance, our local outbreak management plan, that is continued to be refreshed. So we've got all those tools, but it's just in the sense of this is now normal. We're living with COVID, and I'm not using a glib statement there. It's just as we live with TB or any of those other infectious diseases, I don't put those on the risk register, not because I don't feel that they're unlikely to happen, because they do, but actually I believe that should they happen, I'm in a position as a Director of Public Health to then push the right buttons, and we've got a system that, without boring members, is ongoing. There isn't any slackening off from the way in which we review the data, we look at the threats, we respond to those incidences, and we are still testing, as you're aware, in certain circumstances and contexts. We still have got our eye on the ball, let's say. You'll have seen in the papers that there's been a slight uptick in terms of cases across the South East and in London. The reason for that, I think everyone will understand. We've had a long weekend, there's still COVID out there. We haven't said that it's gone away. People have come together, Queen's Jubilee celebrations, other events. We had half-term before all of that. So it's just one of those natural things. But what we haven't seen, and I do monitor this, is a surge, and Jackie would tell me as well, a surge of additional admissions into our acute hospitals where people are being really poorly. We still get people with COVID who are admitted, but not because they've got COVID. It's a coincidental finding. They're going in for something else. So we've got surveillance system, we've got response system. I chair the local health, you've got local health resilience partnership. We've got meeting of that. COVID is on there, so we do have it there, but just in terms of the council specific risk register, there is an acceptance now that I can deal with that. And if I do need to call on the resources of the local authority to respond, then I can do that. So that's, it's not the answer that you want to hear, but it's the answer that I can give you just to give you reassurance, is that we haven't not thought about what we need to do should a pandemic of other forms shape, regardless of whether it's COVID arise. And clearly we'll take the learnings from the public inquiry.
Yeah, just responding quickly, Chair. Look, I understand that, James. And for all the other things you've mentioned, we know a lot about them. We know how Legionnaire's disease behaves and where it's most likely to occur. A lot is known about TB, and we have had new waves of it. But nothing much has changed. For me, as a layperson, COVID is too new to make those assumptions in its entirety. And I suppose, I'm pleased to hear that the response plan is updated, and I'm pleased to hear about the surveillance. I would expect nothing less. But I wonder if it puts the council in a weaker position, not having it on the risk register, if there was a problem and we needed more resources.
I do understand what you're saying, but I believe that should I need to, because clearly it falls within my gift, I've got the authority to direct the council's resources to respond, the chief executive, and I'm sure that the leader would back me in terms of my statutory responsibility to respond. I do feel that I've got the appropriate tools should we need to use them. That isn't underplaying the challenge that you've given to me, which is clearly COVID is new, it's one of those diseases, but actually we do know quite a lot about how it's transmitted and the risk mitigation. And those are the things that we rely upon now to keep that in check, because we've got the national steer with it. If things change, we will respond. That is set out there, because we're a Category 1 responder. But it's not the council on its own that needs to carry that burden. And that's why I reflected and just sort of try to remind members that there is a whole system and an infrastructure of response that is looking at this particular thing and is not sort of leaving it alone. Their eyes are on it, and if there is a need for us to flesh, all the response system is still in the background. There is mitigation. The teams that we've got that we're out there doing testing, you've seen them doing other things, we can call upon them. So I've got the mitigation in place. I do hear what you're saying. I accept your point around whether the council's got enough of a focus on COVID, but from my perspective, I would suggest that we have, because that would fall down to me really to advise the council. I do think that we've got the appropriate tools in the armoury.
I don't want to labour it too much, but it's on that point against James, and I understand obviously it's your decision, and I've got to say it again. We done a really good job. You done a good job, you and the team, all during COVID. It was great. But for me, in my day job, on my risk register, it might say my building's going to blow up or my IT infrastructure is going to collapse, and I'll have the best IT team, and I won't have any explosives in the building, but it will still be a risk, and I'll still keep it there. And I understand what you're saying around your reasons, but tonight, for example, we've had some very good discussions with partners tonight. As soon as, and it isn't being critical, as soon as we turn up the burner, it's COVID. From everyone, even, from the people tonight, it's COVID. It's because of, like Councillor Murray said, the fallout from it has been tremendous. So I don't quite get why we just didn't, even for your own safety and security, why we just didn't keep it, even at a low or moderate rate, why we just didn't keep it on there as a high rating just for now, because we've only just come out. I mean, we're not totally out. We haven't had boosters. We don't know what's happening with that yet. We're not out of it. So I've got no doubt that you would respond to it, any problem. I've no doubt because you know what to do. But it just doesn't, I know we can just harp on all night, Chair. I'm not going to, but it just doesn't, it just doesn't make sense to me. So from when anyone else comes tonight to meetings in the future, I'm going to say, it's not a risk for us. It's don't keep talking to me about COVID because it's no risk for us anymore. So you've got to get over that. You've got to get on and see people. I know I'm sort of simplifying it there, but.
So the challenge is just probably for me to be really clear. We are still responding. I've explained that, hopefully I have, that we have still got the plans, we've refreshed them and we've updated them. You mentioned a couple of bits there about the vaccination programme. We're planning forward the vaccination programme for those eligible groups when the Joint Committee on Vaccination and Immunisation provide us with a steer on all of that. The levels of infection, and this is the proportionate bit, and I'm looking forward, that we're currently at now, do not require me to be really standing there and saying, actually, we have got a significant problem. And the reason why I can be clear about that is because at this moment in time, we are not seeing the impact of COVID on our population. And the reassurance is that if we do, because I'm looking at this data, then I'll be the first, as you can probably imagine, to start saying we need to start to think about this. But the generality of that is that we have got a particular committee, which I mentioned, which is our Health Protection Board. We've got one that straddles all of these issues where we do take COVID into account. The challenge for members is the tools that we have got to respond to that particular challenge are now within the general tools and powers that we've got as an authority in the public. We haven't got specific, other than you can do remote meetings and things like that, that they're retained in court proceedings. But there aren't any other additional control measures that we have actually got now, other than what I could use should we have an outbreak of something nasty in a particular place or other. So we've got to be proportionate about that. And the recognition that I think members would accept this, we've got the capability to flex up. But I can't underestimate the challenge of retaining a state of readiness for people and a whole infrastructure where actually at this moment in time and for quite a period, there hasn't been that requirement. We don't do community testing in the way in which we did it before because it's now more targeted and nuanced. We don't do all the stuff that we did in workplaces. Why? Because the guidance is there about COVID security. So what we've done is we've included all of that kind of infrastructure into this is how we need to live our lives now. And I know I'm not trying to be glib with that, and I do accept all the points that you've raised and made to me. I'm not trying to downplay that at all, but I'm just trying to give you that assurance that I accept the points that have been made, but I believe that we've got appropriate mitigation in train should we need to respond. And I can't do anything outside of that because central government have given the direction which is set out in the Live With COVID strategy for us to move as a country away from all of those restrictions. So that's the black and white of that.
Chair, just briefly, I'm just coming, one second. I totally get that, James. I totally understand. But please, the colleagues opposite, don't think I'm going to have a crack at the government about this. However, The risk is still, will the booster programme go ahead? Will there be money for it? Will it happen? You know, we hope it would. So it's not, I'm not having a go at the government. Those colleagues over there know me, I'm not. I'm just talking about, you just don't know whether it will be done in time, whether we get the booster programme in time, when it will happen. So for the sake of just keeping it, on the register. Anyway, let's not. You're not going to change your mind, but the points that Councillor Murray made, I'm making is just that it is key to do that. And before there's a big response, me criticising the government, I'm not, okay? I could, but I'm not. I'm just saying none of us know what happens over the next year. You don't know whether there be a second, whether there be a certain different wave or a different, we just don't, you'll be able to cope with it, James, but I just don't understand why we just didn't keep it on there anyway, but I won't harp on about it.
If I can, Chair, just really quickly, the spring booster programme is in train and has been in train, and there is an evergreen offer for vaccination. And my call to members would be to keep encouraging people who are eligible to come forward. I think we've got to make a distinction between a mass booster campaign for the whole population, and actually that's the distinction where the Joint Committee, and it's not the government, it's the Joint Committee on Vaccination and Immunisation, who will advise the government as to which groups of our population may well benefit from another vaccine in the autumn, but just to reassure, the vaccine programme is ongoing. They haven't stopped that. It's still running, and people can still get vaccinated should they so wish to do so. I understand the point.
Thank you. Does that answer all your questions? I think James has answered it pretty much in depth, so I'll move on then to count.
I just wanted to say I totally do get James's point. The purpose of the risk register has been fulfilled in this sense. The infrastructure has been embedded in the system. There are national levers that are in place. You have the Joint Committee who lead on this. We have the new Biosecurity Centre that does testing. And absolutely, the money and the planning for the future vaccination programme for this autumn and winter is already completely approved. It's already entrenched, and some people have already received advance invitations. So I think we need to be really careful. I totally get it. Let's just call it a day.
Thank you, Chair. So, on item agenda 8, I move that we note the Q4 2021-22 performance against the measures used to monitor progress against the Council's priorities.
Is that agreed? Seconded? Right. Then we move on to Michael. I'll give you 5 minutes, Michael, to do that, and then move on to the work programme.
Yes, thanks, Chairman. There's a bit more in this report than usual. I wasn't intending... Sorry.
It's all right, it's moaning at me. It's moaning at me because I haven't got my microphone.
Okay. Right, I'll start again. Yeah, there's a bit more in this report than usual. I wasn't intending to go through it in any great detail, but more than happy to take any questions members have.
I will put my microphone on. Is there any questions? No? So we agree the work?
No, just a minute. Thank you very much. I'm pleased to see we're seeing the Chief Executive. On the item on women's health, and I know I've banged on about this, Michael, before, the government call for evidence report is available now, and I think it would be useful to have some distillation of the statistics in it. For example, things like the fact that the waiting list for gynecology procedures is higher than any other type of procedure, because it isn't just, the sort of general importance of women's health. That call for evidence, and the reason I wanted to make sure that we looked at it is because there is a perceived gender bias within the NHS, I'm afraid, against women. If you look at the conditions that only women suffer from and the things that only women do, I'm afraid the services and the waiting lists, and you can look at the government report for yourself, Chair, are in a much worse state than other things, particularly gynecology. which can cause a lot. So I just think if we could have some sort of distillation of the statistics, that would be really helpful. And I hope that the item can look at the changes that we need to make. It won't be the be-all, end-all of it there, but it is a pretty important item, both in terms of equality and the health and well-being of our population, for the biggest group of people in it.
Okay, thank you. I've made a note of that for when we get to the report.
Then I'll move to the Vice Chair.
Thank you, Chair. Yes, I move that we approve the proposed work programme as set out in Appendix 1.
Okay, is that agreed? Seconded?